TopMedTalk.
All right, well, welcome to TopMedTalk. I'm Desiree Chappell, and we're coming to you from the 5th Collaborative Clinical Trials and Anaesthesiology Meeting here in Prato, Italy. I'm joined by Chief Editor-in-Chief of TopMedTalk, Monty Mythen. Hello, Monty.
Hi, Desiree. Meeting's going really well here. Very exciting. Just been hearing more results from big trials that we can't tell you about.
Chatham House rules is you can say something about it, but embargo means zip it, right?
Chatham House rules are you can say what you heard, but you can't say who said it. This is don't say nothing about the results unless they're already published. Now, you can talk about the trial design, the motivations, etc., etc. And we've been lucky enough to see many of the results. There's a lot of exciting stuff coming down the pipeline. A lot of reinforcement of ideas, a lot of surprises, but we can't give the results away.
Just for the listeners that are just joining us, what exactly is this Collaborative Clinical Trials Meeting?
Put together by Paul Miles and his colleagues from Monash University in Australia, utilising their lovely facility here in Prato in Italy, just north of Florence. This is the 5th, and it's done every 2 years. And I think Paul Miles was reflecting last night, not really that much to talk about in the first meeting compared to where we are now. The Australians very much have sort of led the world in many of these very, very large pragmatic trials. But over the years, and this is my second, the number of trials to discuss is starting to overwhelm the programme, which is great. Not only the fact that we're seeing the results, but people are teeing up really massive trials that are starting to look like the sort of tipping point in cardiology, where we were getting real answers to really important questions.
Well, we've had an opportunity. Paul's been so gracious to let TopMedTalk interview and talk to some of the people that are here and talk about the meeting. And we've had the opportunity to catch up with Toby Richards, who's a professor of surgery. Used to be at UCL, but now you're joining the Australian crew. Hi, Toby. How are you?
I've moved from UCL over to Western Australia. I've actually also got an appointment at Monash as well, so I'm spread across the hemisphere.
So that's a good thing. So, Toby, you presented yesterday, and again, we know that everything is embargoed, but can you tell us a little bit about the study that you've been working on, just a little bit of background on that and how that's going for you?
So this all started some time ago. My baseline job is a vascular surgeon, and the question I asked was, if we properly mobilize our patients, if we feed our patients and we correct the anemia, will our patients do better? And particularly in vascular surgery, where we have a high morbidity and mortality rate, will we reduce that by optimizing our patients? So the question is, can I get a patient fitter for surgery? So we started by looking at whether or not anemia is common in people coming into hospital. And we analyzed the US Veterans Database of 250,000 people, 1/3 of whom had preoperative anemia. And on multivariate regression, anemia was independently associated with a 2-fold increase in mortality and a 2-fold increase in complication rates. So on average, those patients spent 50% longer in hospital. That associative data has been repeated in 28 other associative publications, and there was a meta-analysis in the BJS by Fowler and Rupert Pierce's group confirming what we've said. So the question is, if you've got someone who is anemic, can I correct that anemia prior to surgery? And consequently, will that patient feel better and do better during the perioperative period, and then rehabilitate faster with reduced readmission rates to hospital over the subsequent 6 months? The mechanism is interesting. Globally, anemia is very common, and iron deficiency is the commonest nutritional disorder and the commonest cause of anemia. This can be directly from nutrition or from women's health, heavy periods, or secondary to renal failure. This is slightly different in the surgical population because although that might represent some of the causality behind anemia, people coming in for an operation have often got blood loss due to cancer and bleeding in the gut in colorectal surgery or gynecological surgery. But also they have an inflammatory process going on. And in the setting of inflammation, normal iron pathways are disrupted. And although you can eat iron in meat or take iron tablets, the absorption is blocked due to inflammation. So we used to call that anemia chronic disease, and we now think that that is iron-mediated and a functional iron deficiency. So our starting point is a third of people are anemic, and we believe the vast majority of those people, it's due to iron deficiency. So, next question is, can we treat iron deficiency anemia in that setting? And the answer from observational studies is yes. We can use an iron infusion. So 8 years ago, 2 new preparations of intravenous iron came out. These are safe, and they enable a total treatment dose up to 1,000 milligrams of iron delivered intravenously in 15 minutes. So that's something that you could feasibly introduce to a perioperative pathway in the future. So we have a problem, we have an intervention, and an intervention that could fit into a pathway. So we took people prior to major open abdominal surgery. So that's people who bleed a lot and spend a long time in hospital with a high morbidity load. And our question was, in 2 weeks prior to surgery, if we give them intravenous iron, do we treat the anemia? As a consequence, does the patient feel better? Therefore, at operation, do they receive less blood transfusion? Post-operatively recover without as many complications and rehabilitate well out to 6 months.
So you're a surgeon, that's very different than most of the people here. It's mostly anesthesia. How does that make you feel, Toby?
If only I had as many willing anaesthetists on my day job, yeah. No, look, I think, the interesting thing about the perioperative field is it's a field that falls between specialities. There are anaesthetists who are interested in perioperative medicine, and now you have geriatricians interested in, for instance, the fractured neck edema pathways. Who does it probably doesn't matter, but there's definitely a need for care of patients around the surgical pathway, and to break down these barriers of, well, that bit's not my job. It's joined up thinking and continuity of care. We need to go back, I think, to the preoperative period and actually address what we're doing in that period. We're well aware that patients come to preoperative assessment, but my feeling is that that's become more of a tick box exercise to facilitate rapid admission to hospital, reduce length of hospital stay, and enhance recovery. So more administrative and process rather than individual patient care. I started this conversation by saying I've got the highest risk patient group, and every anaesthetist listening to this will just moan and talk about vascular surgeons and the fact that all we do is chop legs off. Well, we do, but actually, we do have the highest risk patients, and we do need to define who we should operate on. And in those people that are high risk, the question is, how do we correct that risk? So I think that's really important for the surgeon, because we're ultimately putting knife to skin, and we're also the people that follow people up at 3 months and 6 months. So like it or not, the butt, I feel, does stop with us to some degree.
No, I just wanted your perspective because I think that's interesting. And I think we all need to hear that and continue to have the conversation. So I think that's good. So on your, the study that you did, is called PREVENT, right?
Preoperative intravenous iron to treat anemia. Work it out for yourself. Look on the website.
That's good. Actually, you do have a website for it?
We do have a website for PREVENT, and then we got a variety of patient forums, Facebook pages, etc., all to do with iron therapy. It all comes under the Iron Clinic, if I'm allowed to plug that.
Yeah, absolutely you are, for sure.
So, Toby, I was around at the start of the journey for the design of this trial, and at the time, very ambitious, very novel, going for an adequately powered trial in adult patients undergoing major intra-abdominal surgery, getting this single intervention in a multi-center trial, randomized control trial. And part of the challenge there was it's a double-blind trial, which I remember lots of discussions about that. How did you pull that off?
So the problem is that iron is a black liquid. So the way we did it is you can use a black giving set, and then you can cover the infusion bag with one of those opaque TPN covers. The patients were consented, and they would go to often a different unit, so a day case ward or to a treatment room, and there'd be an unblinded person who would prepare the drug, load it up into 100 mils or 200 mils of saline, run it through, and put a line in. In the United Kingdom, you're not allowed to put an airline mask on the patient and blind the patient, okay? But you are allowed for them to have their arm hidden by a screen or a blanket. So they have a Venflon put in, and then you'd either start with infusing normal saline, then cover the arm up, so you know that it's all fine, and then you change the IMP accordingly. We actually specifically asked, and so for those listening, how do you test blinding? Well, we asked the patients, and exactly half of patients said, I had no idea what I got at all. Half said they got iron and half said they got placebo, so it's an even spread. And we will then marry that up to test the quality of our blinding and concealment.
And you ended up your power calculation, I think, with about 500-ish patients?
So at the time that we planned this, which is almost 10 years ago, 40% of people undergoing major surgery were getting a blood transfusion. I felt, as a surgeon, that reducing from 2 units of blood to 1 unit of blood or 3 units of blood to 1 unit of blood actually clinically doesn't make much difference. We tend to think transfuse a patient or not. So clinically I felt that transfusion or not what should be the primary endpoint. We anticipated with intravenous iron that would increase hemoglobin by 5 to 8 grams per litre, so not a massive amount, but that would be enough to reduce blood transfusion by about 15%. And that's how we powered to 500, allowing for a 5% mortality and a 5% dropout rate.
And recruitment was going really well after a few initial hiccups and some challenges with some of the exclusion criteria, and then along came a set of NICE guidance. These are guidance in the UK for at a government sort of level, which implied fairly heavily that actually giving people intravenous iron preoperatively was the right thing to do. Yet you're in the middle of a funded trial that's asking that question.
If you'd like to discuss it over a beer, I'll be happy to do that and give you my proper opinion.
That was a challenge.
Yeah. So there are two things. One, when we designed the protocol, we wanted to be scientific. So we wanted to bring people after their IMP, we wanted to bring them back 2 weeks afterwards to say, yeah, you've had your IMP, not sure if it's placebo or iron. How do you feel? So let's do a quality of life assessment. Do these people feel better? Do they feel fitter? Patients won't come back before surgery for research. So we lost a good 6 months at the beginning and realizing that and having to change the protocol to change that. We were then recruiting very nicely, averaging 12 to 14 patients a month. NICE came along and we were straight down to 5 to 8. It was a really big problem. We actually got a letter from the head of NICE saying that they fully supported the trial and they regarded being in the trial as compliant with NICE guidance. But yeah, it was a huge problem, a really huge problem. And so consequently, we finished 6 months later than anticipated, and we got 487 patients out of 500. The results are still powered for 90%, and we received. And so we're now powered for 88.7%, so not much in it.
Congratulations, and we know that you're just getting the results through now and they're embargoed, but we're going to hear them, we hope within, maybe this year, but certainly within the next year. It always takes a lot longer than one anticipates, so congratulations to you and everyone for managing to finish that.
Thank you very much, and I think if you believe in clinical data and clinical trials, and those listening to this podcast, by definition, are here, and listening because they want to hear data. The only way we can get data is if every single clinician buys into the reason why they need data. We don't know best. We think we do. But often we're not right. And we've had shows of hands today at this meeting about, with my trial, what do you think the result is? Do you think it's A or B? And uniformly, the audience of professional trialists have been wrong. Okay? So if you're listening to this, if you see a patient who's eligible for a clinical trial, think the clinical trial first, because that's the only way we can develop and push forward data so that we can offer better care to our patients.
Thank you very much for saying that, especially after being here this weekend. That is ever more poignant. But so moving on to one other topic we wanted to talk to you about. Monty had mentioned that you had done some work and it was called The Iron Woman, which is an interesting title. Can you tell us a little bit more about that?
I've worked in this field now for almost 2 decades, and in the perioperative medicine. And when you were looking at patient fitness and outcomes of surgery, we've got to think breadth. So I can't take a 75-year-old person undergoing major surgery and stick them on a treadmill or do a CPET test to utter exhaustion. I can, but their VO2 max might be so low that seeing a margin of gain of 5%, I just won't see it because they might have arthritis of the hip. So we've got 2 sets of experiments going on. We've got laboratory experiments comparing iron-deficient functionality to iron-replete, and then we wanted a group of fit and healthy human beings. And this was quite a revelation to me. Not so much about women's health, but more the impact of women's health on their mental and physical capacity. And so we started by asking a question of, well, how do I find a group of people that I can stick on a treadmill who are used to being on a treadmill, i.e. athletes, and how can I find a group that are suffering with iron deficiency? Well, men don't get iron deficiency. Women do get iron deficiency secondary to menstrual health. And so we started off by asking, well, is heavy menstrual bleeding common in athletes? There's an assumption that they're all amenorrheic. So we did a questionnaire based on 4 questions. Do you have flooding, have passage of clots, need to double protect, or have to get up at night time to change your protection? So 2 out of 4 of those symptoms would indicate heavy menstrual bleeding. So we asked 1,000 marathon runners at London Marathon, and we found that 25% had symptoms compatible with heavy menstrual bleeding. We checked this on social media. We had to close that because clearly it was a problem. And then what we did is we went to a civil service half marathon and we offered free blood testing to all women doing the half marathon. The incidence of iron deficiency anemia was around about 11% in 200 people tested. If you had heavy menstrual bleeding, it went up to 25%. So we clearly had identified a population. We then advertised, and many thanks to the Vegan Marathon Club, because there was a lot of iron-deficient women there.
I'm vegan and a runner.
What's your ferritin?
Not probably good enough.
So we identified a huge group of women that had iron deficiency. We then put them on the treadmill to complete exhaustion. And being athletes, they kind of like that, and they want to do it again. Patients don't. And we gave them intravenous iron, and we retested it. It was an observational study, high bias, because they're expecting to feel better. But we saw around about a 5% increase in VO2 max in 2 weeks, and that's the equivalent of 3 months of high-intensity training. Now, this was a very biased study. It didn't quite reach many statistical significant results. Clear trend, so we're now repeating that in a randomized crossover trial.
Monty is always telling me about, because I am vegan, and I used to run. I haven't run so much lately, but always complaining about how I feel. It's like, you got to get your labs drawn because you're the typical person.
How's your hair?
I'm not going to say.
So interesting. We run a Facebook forum on women's health, and there are 3 populations, vegetarians and vegans, heavy menstrual bleeding, and recent mothers. Some fascinating data coming out about recent mothers. And if you look at postpartum anemia and you randomize women between intravenous iron and oral iron, you reduce postpartum depression by 35%. I think it's huge. It was published by Charlotte Holm in Vox Sanguis. It was actually her PhD project. It's a fantastic study, and we're really looking to reproduce that at a bigger level.
What are the levels of for those particular patients with anemia?
Well, first up, I haven't found anyone who can explain to me why women have a hemoglobin of 120 and men have a hemoglobin of 130. All I can say, it was a panel of 9 men in the 1950s from the World Health Organization, and I'll say nothing more there. But if you've got a hemoglobin below 130 and a ferritin below 15, you by definition are iron deficient. And from the preliminary results that we have, I can pretty much guarantee that you'll feel better with treatment. Pretty much guarantee. Commonest symptoms of iron deficiency are fatigue, tiredness, lethargy, but also mental fatigue, mental tiredness, lethargy, reduced cognition, or brain fog. Other symptoms include restless leg, palpitations, chest pain, shortness of breath. But the one thing that women won't tolerate is if you mess with their hair. Okay? And so hair that has increased shedding, increased cracking, or if you've got long hair and you put it up in a bun, the bun size is less, that is normally due to iron deficiency, and it responds to iron therapy.
So, just to disclose, I have all those symptoms, and my hair is falling out. And I've always said, I tell you, I was like, my hemoglobin was like 13 or 130. I'm like, I'm fine. That's reasonable. Like, 130. I mean, do you think that's reasonable? I mean, I would think someone that's having like major symptoms that you would have to be lower than that.
I think you've hit the nail on the head, because I'm talking about iron deficiency, and you've answered by talking about your hemoglobin. Yeah. It's a separate thing. So iron, you need around about 4,000 milligrams of iron in your body. You have about 1,000 milligrams hanging around in reserve, which is about the same as a baby requires. You then, after you've used up that 1,000 milligrams, you then sequester your iron from elsewhere in the body, the muscles, the nerves, etc. And that's why you get the symptoms that are very broad and very specific. Finally, you become anemic when the bone marrow is completely devoid of any form of iron. So it's just like kidney disease, stage 1, stage 2, stage 3, stage 4. Anemia is dialysis, but you feel lousy for a long time before that. And the average woman suffers with symptoms of iron deficiency for 8 years. So it's a decade.
So I think next phase, so since you're here and I have you, doctor, from your work and experience, not everybody can get IV iron. In the U.S., it's just not, it's becoming more available and people are looking at it. But, I'm not going to take iron supplementation. We know that it's not really that effective, right? Or is it?
Following on from what I just said, 20% of the people that we treat have a hemoglobin above 130 and a ferritin below 15. The first-line treatment is good quality diet, and that's a diet rich in meat because there's a specific meat-heme iron absorption pathway, and plant iron is absorbed through a separate pathway. So for plant iron, you need a very acid-rich stomach, pH less than 1.8. So if you're on omeprazole or other PPI, you instantly decrease absorption. It's only absorbed in the duodenum through something called divalent metal transporter 1. So if you've had a gastric bypass, you can't absorb iron. And you need to avoid alcohol, tea or coffee for 30 minutes either side of eating because they inhibit absorption. So first up, diet. Second up, iron tablets. So it doesn't really matter which iron tablet. If you go on to any social media, there's hundreds of companies selling you all sorts of rubbish, Kardashian diet, I call it, magazine medicine, whatever. But iron tablets are essentially an iron salt. So ferrous sulfate is 200 milligrams, but the elemental iron component of that might be around about 60 milligrams. You need 60 milligrams of iron once a day, because as you take the tablet, the body goes, wow, I've got loads of iron, and it activates hepcidin that blocks absorption. Same as thyroid and TSH. As soon as you've got some, you limit the reabsorption. And that process actually takes 24 hours. So current evidence is that one tablet alternate days is just as good as taking a tablet every day. So that's the first line treatment. But up to 30% of women won't respond to dietary supplementation. And much I'm loath to say it in the same thing, NICE guidance kicks in here, NICE NG24QS138, where oral iron has failed or is not tolerated, then an iron infusion is indicated. So in England, UK, and Europe, where NICE has influence, simply say to the doctor and to the healthcare professional, this person conforms with NICE guidance, so should have an iron infusion. And, it does work. So we do a lot of advice on social media, and patients can download this document and go to their healthcare professional and say, look, I need an iron infusion. Availability is increasing throughout the UK. In America, it's a huge issue, huge issue.
a ton of our listeners and just a ton of my friends, the message that they would get from this is huge because we're all experiencing that. I think middle-aged women that have had kids and whole deal. So that's really good information. I'll have to take it. Monty?
Now, treading carefully here, having looked into this a little bit in the UK, if you decided to go down a self-pay route, this is not an expensive... It's going to be expensive to some people, but it's not a wildly expensive decision to make.
So, slight conflict of interest here, and I'll have to declare it. I run the only private outpatient clinic in the UK. It's called the Iron Clinic. It started because when I was doing the Iron Woman study, it was actually cheaper for me to form my own company as a service provider to give the iron privately rather than to bring fit and healthy patients in through a hospital pathway because of the processes and costs involved in doing that. So it started like that. And one thing that I've learned is women talk. So the phone started ringing. So the Iron Clinic is staffed by my PhD students. You can look us up on Companies House. We make no profit. I take nothing out of it. So women self-refer, and it costs £770 because by the time you've paid the CQC database, all the rest of it, there's overheads, and the PhD students, they like to be paid. They won't work for free anymore, unfortunately.
So it is an option in the UK then if that's not something that you're fishing in. And I'm probably in the US.
It's a problem in the US because of insurance driven. Yeah. And so the more modern preparations allow a total dose infusion in one go, just in 30 minutes. However, insurance coding often means that people will use the older iron sucrose Venofer preparations, and then they suddenly have 5 sets of codes that are reimbursed. And it can end up being about $5,000. So we actually have people fly from America to the UK to London, stay for the weekend, have an infusion and go back, and it's cheaper.
So I'm going to be in the UK over the next couple of weeks. I may have to come to see you guys. That's so true. That's such great information, Toby. Thank you so much for sharing that and talking about what your upcoming clinical trial, and hopefully we'll see those results. And I appreciate it. Good luck on your move to Australia. I hope that goes well for you, and hopefully we'll talk to you soon. Thank you so much.
TopMedTalk.
Nick Majerison here. Thanks for listening to TopMedTalk. Now, before we let you go, it's important that we remind you to subscribe to TopMedTalk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com, and click on the section marked email updates. Finally, TopMedTalk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on TopMedTalk. That's ebpom.org/meetings.